vi presentiamo il caso di questa paziente.
We present the case of this patient born in 1972, a woman, who came to the outpatient clinic with pain in her right knee, a 𝘱𝘳𝘰𝘧𝘦𝘴𝘴𝘪𝘰𝘯𝘢. The patient has a history of ulcerative rectal colitis, therefore, she has been exposed to significant doses of cortisone throughout her life. As seen in the corresponding images, the magnetic resonance reveals infarcted areas in the distal femur and in the proximal tibia. She also exhibits second to third stage chondropathy in the medial compartment, leading to the decision to graft a bone substitute using the ORTHOPLASTY kit in both the distal femur and proximal tibia.
Orthoplasty is a single-use device specifically designed for the treatment of subchondral bone lesions by applying bone cement within the subchondral bone. This innovative tool is crafted to effectively address conditions such as bone marrow lesions or avascular necrosis across various bone locations. The working cannula consists of an external cannula and a dockable internal stylet equipped with a trocar tip. The drill features a threaded terminal portion for enhanced precision during the surgical procedure. Bone fillers include an internal pushing stylet, a lock connection, and distinctive marking signs. The arrow indicates the side of lateral holes. When at the cannula neck, the marker indicates when the holes are fully extruded from the cannula. The surgical approach employs a minimally invasive technique under fluoroscopy guidance, allowing for precise targeting and management of intra-articular findings. Upon determining the trajectory, the surgeon gains access to the lesion. If necessary, entry is facilitated by gently tapping the plastic handle with a hammer. The internal trocar stylet is then removed, while the working cannula remains securely inserted. Subsequently, the drill is introduced into the working cannula and attached to the cannula's handle. Handle it to target the designated treatment area. The bone substitute can be loaded into bone fillers and propelled into the bone using the pusher stylet of the bone filler. The surgeon withdraws the drill and introduces the directable release bone filler into the working cannula. Guided by the arrow imprinted on the handle, the surgeon manually rotates the lateral holes toward the lesion, confirming the position relative to the preoperative plan. To inject larger quantities, bone fillers can be directly connected to the bone substitute syringe, thanks to their lock connection. The surgeon repeats the whole operation on the proximal tibia. Previously extracted bone marrow aspirate, rich in stem cells and growth factors, is injected into the joint to promote healing and reduce inflammation.
We utilized approximately 14 cc of bone substitute, 8 cc were implanted in the femur, and 4 cc in the tibia. Subsequently, we performed a harvest using the marrow stem kit for bone marrow stem cells and intra-articularly implanted around 5 cc of stem cells. In the postoperative period, a decision was made to observe 7 days of non-weight bearing with range of motion recovery exercises and immediate quadriceps femoris toning. At 7 days, a protected weight bearing with 2 crutches and 2 Canadian canes with intolerance. At 15 days, a gradual resumption of activities.